Okay. All right, so I'll just get started with brief introductions while people continue to join. I've introduced myself over the last few meetings. I'm Dr. Elisa Ignatius. I'm an infectious disease physician and clinical pharmacologist at Hopkins, and I now co-lead this NTM case conference with Ruvandi and Colin. Colin may be in clinic right now, so not sure if he's joining quite yet. But today we have the pleasure of having Dr. Jessica Little present a case of the use of bacteriophage therapy to treat a case of disseminated cutaneous Mycobacterium cheloneae infection. So Dr. Little attended medical school at the University of Virginia School of Medicine and completed her residency in internal medicine at Brigham and Women's Hospital in Boston. She graduated from the Infectious Diseases Fellowship Combined Program at Mass Gen and Brigham and Women's in the Transplant Immunocompromised ID track. She is currently a Transplant and Immunocompromised ID Research Fellow at Brigham and Women's Hospital and the Dana-Farber Cancer Institute, where she is conducting clinical research and clinical trials. And with that, Dr. Little, you take it away.
Thanks so much for the introduction, and thanks so much for inviting me. I'm very excited to have this discussion today, and I'm going to go through the case in a little bit more.
Oh, sorry, Jessica, I just accidentally muted you. Sorry, give me one moment to fix that. My bad.
But yes, please feel free to pause me at any point with questions or comments about the treatment course. I'm really excited to hear everyone's insights. So I have no disclosures. So we'll get right into it. So this was a 56-year-old man with a history of myxomatous mitral valve prolapse who had a mitral valve repair in 2014 and seronegative arthritis, had been treated most recently with tofacitinib and prednisone, who presents with nodular lesions on his left upper extremity, as well as weight loss, night sweats, and malaise. This is an image of the lesions at the time that he initially presented. A little bit more about his history. He had been diagnosed with seronegative arthritis involving his hands, wrists, knees, and ankles about a year prior to his presentation in January of 2020. And he had been treated with multiple immunotherapies, including etanercept, adalimumab, methotrexate, and most recently had been on tofacitinib, a JAK inhibitor, as well as prednisone at doses up to 40 mg per day for flares. And at the time that he presented, he was on 10 milligrams daily. He endured several months of waxing and waning nodular lesions, primarily involving the left upper extremity. And these were associated with flu-like symptoms, including myalgias, weight loss, and night sweats that had really progressed over the recent weeks. So he was in dermatology clinic and he underwent a biopsy immediately, which fairly quickly came back with Mycobacterium cheloneae. On the culture, his pathology also showed abundant mycobacteria on staining, and he had necrotizing granulomas on pathology. And these were his initial susceptibilities. So I wanted to start out with a poll question, and I think many of you may know the answer to this if you're routinely treating these patients, but what is the most common clinical manifestation of M. cheloneae infection? Pulmonary, bloodstream, bone infection, cutaneous infection, or endocarditis? We'll give it a minute.
Yep, about half, more than half, 70% of people have responded. Give a couple more seconds. Okay, and I'll end this now and share those results.
Perfect, yes. So good. Cutaneous infection, I think, is the most common manifestation of M. cheloneae, but can manifest in a wide variety of presentations, which we'll go through now. So Emsheloni is a rapidly growing non-tuberculous mycobacteria. It's ubiquitous in the environment, and it causes a wide spectrum of disease. Cutaneous infection or disseminated cutaneous is the most common presentation that's been reported in the literature, and nosocomial infections can also occur during procedures such as plastic surgery or exposure to contaminated equipment or substances in healthcare settings or in the community, such as tattoo parlors. So this image is from a case that was reported in the New England Journal of contaminated tattoo ink that led to an outbreak of Emsheloni infections. And these sorts of outbreaks have been reported in multiple different settings. Wallace et al. Did a paper looking at one of the original papers looking at over 100 cases of Emsheloni infection and characterized into 3 major types of cutaneous disease, which I thought was quite helpful when thinking about the presentation of our patient. So the first type they defined was disseminated cutaneous disease, which is described as 5 to greater than 100 nodular subcutaneous erythematous lesions, often with spontaneous drainage. Sometimes these can have expressible, thick, white necrotic material. They tend to be non-linear and non-sporotrichoid and can predominate on one distal extremity with scattered lesions on the other extremities seen, and typically won't include other end organs involvement. And then the other types that they defined were localized cellulitis or abscess, which can occur after known trauma or medical procedure, and then catheter-related infections, which have been seen with peritoneal dialysis catheters, hemodialysis catheters, central venous catheters. And in those cases, patients were bacteremic more frequently than in the disseminated cutaneous disease. And then this is to emphasize that these presentations, and particularly disseminated disease, is often seen in patients who are immunosuppressed. And so 92% of the 53 cases of disseminated disease in this report were in patients who had received corticosteroid therapy. And interestingly, a large number of these had either rheumatoid arthritis or other autoimmune disorders, which is consistent with our patient's case. And then this is just to emphasize that, I think that the patients, when we think about patients who are at risk for these presentations, and particularly patients who are immunosuppressed, I think the spectrum that we are seeing is going to be changing in the coming years as we're seeing increasingly immunosuppressive regimens used in patients with autoimmune disease or dermatologic diseases. So this is a letter to the New England Journal where CD19 CAR T cells were used for treatment of lupus. And I think with the rapid expansion of small molecules and other targeted immunotherapies for autoimmune disease, particularly when they're targeting pathways that we might not fully understand the risks for particular infections such as mycobacterial infections, I think we'll need to be on alert when we're seeing cases of these in patients receiving novel treatments, such as our patient with tofacitinib. So our patient had a very long and difficult treatment course before we went on to initiate bacteriophage therapy. And I thought that some of the pieces of his presentation were interesting and probably consistent with what you all have seen in your practice. So I thought we could go through and touch on a few pieces. So when he was first diagnosed, he was treated in a system outside of our system. And he was initially started on tobramycin, azithromycin, and Bactrim. And he unfortunately went on to develop multiple toxicities to that regimen. He had ototoxicity and renal toxicity to tobramycin, and then was trialed on linezolid with severe nausea, and ultimately developed adverse effects that were attributed to the Bactrim. And so that left him on a period of azithromycin monotherapy, all just before we met him in our clinic. And so at the time that we met him in June of 2020, he had recently had a repeat biopsy. He had progression of his lesions up and down the left upper extremity and some new lesions on the right lower extremity and in the periumbilical subcutaneous tissue. And his cultures from that recent biopsy showed new clarithromycin resistance. And so when we first saw him, we had to determine sort of a new treatment regimen to place him on at that time. And so we started him on omadacycline and tedizolid in the hopes that tedizolid might have increased tolerability for him in place of the linazolid. But unfortunately, he developed pretty significant lactic acidosis, malaise, and neuropathy that we thought was related to mitochondrial toxicity from the tedizolid. And so that was later discontinued. And I'll be curious at the end of the presentation to hear if anyone else has had that sort of experience with tedizolid as we start to use it more in this setting. And so then he was placed on omadacycline and clofazimine, but his lesions continued to progress. He had new drainage, new abscesses that were forming. And so at that point, we decided to reassess. And I think the other piece to keep in the back of the mind is that when he first presented, his immunotherapy, the tofacitinib, was stopped at that time, and his prednisone was tapered down to 3 milligrams. And there was a feeling when that happened that he may have had some clinical worsening related to an iris type reaction or a paradoxical reaction. But by the time we met him, he had been on the lower dose of prednisone for a significant amount of time. But we still wondered if there may be some immune modulated process that was driving the worsening of these lesions. And so that's why we decided to go ahead and re-biopsy him.
And Jessica, can I ask a quick clarification question? Was he bacteremic, at the start of this?
Yeah, so when we saw him, in June, when he had just had that biopsy that showed the clarithromycin resistance and he had the new lesions on the other extremities, we did a full workup at that time. We did mycobacterial isolator cultures, we did an echo, and we did a PET CT, which all showed no other sites besides cutaneous disease, and his blood cultures were negative for M. chelonia. So we characterized him as a cutaneous disseminated disease only involving the skin at that time. But yes, so then in October, because he had had progression of these lesions, we decided to go back and re-biopsy him, which we'll get to in a second, but I wanted to pause to ask this poll question number 2. So which antimicrobial is most likely to cause this skin binding?
We're having really good participation on this poll question. So, all right, 84%. I think that might be a record. I'm going to end the polling now. Oh, 88. And share the results.
Amazing. Everyone got it. I'm impressed. And clearly you all have had experience using clofazimine. So this is ichthyosis. Feel free to correct me if my pronunciation's off, but this sort of drying and scaling of the skin that you can see from clofazimine, as well as other dermatologic complications and hyperpigmentation. So great. So at this point, we got a PET CT, and this demonstrates basically that he has this skin involvement involving primarily the left upper extremity, but with some scattered lesions in the right lower extremity. And this was, I thought, extremely classic for, the description where you have one extremity that's affected in the disseminated cutaneous disease, but with some lesions on the other extremities. And then he underwent a biopsy, which again showed abundant AFB positive organisms on the fight stain and positively staining organisms on the fight stain. And then he had evidence of abscesses and necrotizing granulomas on pathology. So to us, this was evidence that we weren't controlling his infection adequately. We didn't feel like this was an iris or a paradoxical reaction based on the pathology, and his culture grew shortly after, showing M. chelonia, and with significant progression of the resistance that he had had on his previous isolate susceptibilities. So it put us in a little bit of a tough place. And So we decided to admit him at that time, and we called it a reinduction, but essentially we started him on meropenem-vaborbactam. We retrialed Bactrim, and we continued on the omadacycline and clofazimine. The meropenem-vaborbactam, we really didn't have a lot of evidence to support its use, but we discussed it with our pharmacists and thought that it might be an additional agent to trial. During that admission, he developed new left wrist pain and swelling that was highly concerning for septic arthritis of that joint. And he ultimately underwent a debridement with orthopedic surgery, who found necrotizing granulomas on all of the pathology, but there was no mycobacteria on staining. And then they did not send mycobacterial cultures from the procedure, which I'm sure is a challenge that we've all run into in our careers. So we weren't able to definitively show that that Mycobacterium chelonia was involving the wrist. Around that time, we had been working on obtaining bedaquiline as a prior authorization approval as an additional agent, oral agent for him. And after several months, we finally got that approved. So we added that on into a 5-drug regimen. And with that, his lesions began to improve slowly. And so due to the challenges of the IV medication and some toxicity that he developed to Bactrim, we tapered those off. And then unfortunately, again, his lesions appeared to progress, to track further up the arm. And so again, at this point, we felt his immune system should have been intact. He was on just 3 milligrams of prednisone, had not been on additional other immunosuppressive agents for almost a year at that point. And we were really struggling as to why we couldn't control this infection. And so we sent him back for another biopsy, which again returned with abundant mycobacteria on staining. The one other interesting piece, which we may want to discuss a little bit more at the end, is in the process of all of this, we did send whole genome sequencing to look for any underlying immune defects that may have been apart from the immunotherapy and immunosuppression he had received that may be predisposing him to this severe infection. And he did have an NLRP12 mutation, which we can talk a little bit more at the end, but is associated with immune response to infections and also with these autoinflammatory disorders, which we wondered were maybe playing a role in the intermittent flaring of his lesions. So anyways, to get back to it, we retrialed him on tobramycin because he was doing poorly. And again, he did not tolerate that. He had developed very obvious oscillopsia. And so we had to stop that. And then finally, in June of 2021, he was initiated on bacteriophage therapy.
Jessica, can I ask a question? So it looked like on the 5-drug regimen, as part of the first reinduction phase, he was having clinical improvement. And I'm curious, when he was reinduced, why you all shied away from the Miro-Faber. I've not used that drug to treat, NTM infections to date, and understand that was kind of a bold move for a desperate case, but just curious about the rationale to switch sort of back to the tobramycin and to drop the clofazimine.
Yeah, so I think the Miro-Faber we had talked about with our pharmacists, and I think everyone was a little bit, it was unclear if it was the right choice to use it in the first place based on his susceptibilities. They aren't able to run susceptibilities on Miro-Faber in the lab at Tyler, Texas, but he was resistant to imipenem. And so I guess there was some concern that it might not be a good agent for him. And it was also very challenging for him to administer at home. So I think after we had discussed with colleagues and even some colleagues across town, that the information about his initial toxicity to tobramycin had been a little bit unclear. And so we felt like it was reasonable to retry it with very careful monitoring, because that was really going to be a good agent to try to control his infection. So that was kind of the thought process. And then the clofazimine was stopped because he developed a prolonged QT. And so he had to be taken off of that. But he did tolerate, I would say, the bedaquiline and the omadacycline are the medications he's tolerated the best since he started. And then the Bactrim, he has intermittently tolerated. So about a month or a month and a half before he was admitted for bacteriophage therapy, he was on a regimen of omadacycline, bedaquiline, and Bactrim. And we'll go through his course, but he's remained on that regimen since then without any changes. Any other questions about this course or any details so far? Great. So going back, we kind of were worried about his case and the level of resistance that his organism had pretty early after we started seeing him. And I was seeing him in clinic with my mentor, Francisco Marti, who has tragically passed away. But at the time, we discussed the concept of bacteriophage therapy pretty early. This paper had come up by Dedrick et al. That showing the use of bacteriophage therapy for an M. abscessus infection in a cystic fibrosis patient, which we'll go through the details in a little bit, but that was really exciting to us. And so it was something that we were thinking about early on. And around October of 2020, when he was not responding and developing progression with the septic arthritis of the wrist, we decided to initiate the process. So bacteriophages are viruses that infect bacteria. They're ubiquitous in the environment. Their replication is dependent on the bacterial hosts, and they're highly specific to the bacterial pathogens with enormous diversity amongst the population. So that brings us to our third poll question. So we'll go on to talk about our phage, but its name was Muddy, that we used in a single phage therapy for our patient. And so where was Muddy the phage originally isolated? A, on a rotting eggplant in South Africa, B, in a manure pile in Tyler, Texas, C, outside of a bagel shop in Indiana, D, in a swamp in Louisiana, or E, near a garden in Costa Rica. I'm particularly excited to see everyone's answers for this.
Got a nice spread so far. All right, give another second. Okay.
Great, okay, good. We've got a good spread. So these are all real places that phages have been discovered that I went through the database and found yesterday. But the answer to ours is on a rotting eggplant in South Africa. So the Science Education Alliance, Phage Hunters Advancing Genomics and Evolutionary Science is quite a name, but the C-Phages program is this really interesting, I think amazing program where it involves students, often undergraduate students, teaches them how to isolate, how to grow phages, teaches them various laboratory practices to be able to expand the population. And then they get to go out and hunt for phages in the environment. And then anytime that a student or anyone at all discovers a novel phage, then they get to name the phage and they put it into this database. So that's at phagesdb.org. And it's very funny to read all the descriptions. So this was Muddy, the phage that we found for our patient. And the sample was scraped from the underside of a partially decomposed aubergine with worms and other insects. So that was kind of my favorite part of that in Durban, South Africa in 2010. The use of bacteriophage therapy to treat infections arose greater than 100 years ago, but its popularity has waned or did wane following the development of antibiotics. Though I think it has been used more widely in Eastern Europe over that time period. And then with the rising threat of antimicrobial resistance, phages have reemerged as a promising therapeutic option. But there are some real barriers to widespread utilization at this time. So one being the slow kinetics, where you need to send your isolate, screen your isolate against a library of phages, and then obtain the regulatory approvals that really can slow down the process. It's not really an emergent therapeutic that you can obtain very rapidly. And then there's also growing evidence on optimal dosing and pharmacokinetic properties of the phages. And finally, there's just been a lot of heterogeneity of the clinical cases and therapeutic approaches that have been reported in the literature, which makes it very challenging to assess the efficacy of phages in various settings. So at the time that we started to consider phage therapy for our patient, this was the paper that got us excited. So this is a paper by Dedrick et al., where they looked at a patient with a 15-year-old woman with CF and a history of disseminated M. abscessus infection who had undergone a lung transplant and developed recurrent M. abscessus infection involving lungs, liver, skin, and the sternotomy wound. And she had been treated with anti-NTM therapies for 8 years prior to her lung transplant. So they sent her isolate to the team at Pittsburgh that's led by Dr. Hatfull, and they exploited a collection of greater than 10,000 phages that they had isolated using M. smegmatis. The phages do not grow well on M. abscessus, are not typically isolated on M. abscessus. They're usually used M. smegmatis. And so they found 3 phages that they used in an IV cocktail and dosed this at 10 to the 9th plaque forming units is the measurement that they used to quantify the phage, and administered this every 12 hours. And later in the course, they added topical therapy as well to the wound. The AEs, the patient experienced some flushing, some diaphoresis that was temporarily related to the infusion, but no serious adverse events, and had a fairly good treatment response. So the skin lesions and the sternotomy clinically improved on exam over the subsequent 5 months. They were not isolating M. abscessus from the sputum or serum after they initiated the phage. And then it did continue to grow from these resolving skin lesions up to 121 days after treatment, but there was no evidence of the development of resistance. And the patient also had no evidence of any phage neutralization, which is interesting given that she was a transplant patient and is sort of at odds with other cases that have subsequently been reported. So to go over the phage timeline, so once we decided that we were interested in this and we were feeling desperate enough that we really wanted to pursue it, the first step is to send your bacterial isolate to the phage supplier for testing of lytic activity. And so we knew that the Hatfull lab at the University of Pittsburgh had been participating in these cases. And so we reached out to Dr. Hatfull with our case to ask if this might be something that they would be willing to collaborate with us on. And they were very enthusiastic and asked us to send the isolate so they could test it against their library of phages. At the time, they had not, I believe they had not administered any phages for a Mycobacterium chelonae infection, although there was one other case that kind of came very close to ours and temporarily. So we sent our isolates, and these are in panel A. You can see these are 10-fold serial dilutions, and the phages, there are all different phages going down from 1 to 22. And so Muddy and Muddy's relative, mutant relative, were the 2 that really efficiently killed our M. chelonae isolate. And then they did some testing of other M. abscessus based phages. And then here in panel C, you can see that the phage and the bacteria were incubated together on a plate, and the phage efficiently killed the bacteria with nothing residual there. They also looked at the killing over time at ranges of bacterial and phage concentrations here, which was promising for muddy. And so after we received that data from the HAPL lab, then we had a really frank discussion with Dr. Heffel. We reached out to some other colleagues at the University of San Diego and other sites that had pursued this therapy before to really discuss whether giving a single phage in this setting would make sense. I think, first of all, there had not been reported any other cases of M. chelonia infections treated with mycobacteriophages, and second, not any cases of single phage therapy. Usually the phages had been administered in a cocktail to prevent the development of resistance. And so we were nervous that this might not be efficacious for our patient. But given that he had few other options, we decided to go ahead and proceed. So then the next step is to develop a treatment plan, and then we submitted this to the FDA to obtain a single patient IND. We obtained IRB approval, and then I would say the thing that really was the most challenging in the regulatory process was negotiating a material transfers agreement between our institution and the supplier, which for us was the University of Pittsburgh. And that process took a long time with the legal teams. And so that was definitely, I would say, the biggest challenge in the process. And just to note that Francisco Marty, my mentor, passed away in the midst of this process in April. And so that, we really wanted to bring this to fruition in his honor, among many other things, and also helping the patient. So after we finally got the approval for the MTA, then we had to arrange shipping of the phage to our investigational drugs services, determine how this would be transported and dosed to the patient. And then we finalized our administration and monitoring plan. We met with nurses and planned to admit him to the hospital. And then we created an epic order, of course, for the phage. And so on June 15th, he was admitted to the hospital to initiate his phage therapy. So for his clinical course, he received his first dose intravenously on 6/15, and then was continued with the same dosing scheme that had been used in the other cases of an IV preparation twice daily, every 12 hours. He also had subjective flushing after the initial doses that lasted up to 1 hour, and he also had some nausea and sweats on one day that resolved shortly after, and then these symptoms subsided after about a week, and he had no major adverse effects that we reported. His skin lesions, so just to pause for a minute, we really wanted to take a multi-pronged approach with him and with the phage therapy. We knew that this was experimental, that a single phage might not have efficacy for him, so we did several things at the same time that I think we wanted to be very clear about in our paper, and I also want to be clear about here. So one, he had a second surgical debridement several weeks before he initiated phage therapy, of the left upper extremity. He continued on his antimycobacterial antibiotics, so that Bactrim, Vajaquilin, and omadacycline, which were the same drugs he had been on intermittently over the past 6 months, and certainly had been on stably for the 1.5 months before initiating phage therapy. So all of those things were done simultaneously to when he started the phage therapy. And we thought of it as a multifaceted approach to his infection. But after that, his skin lesions did improve significantly, and he had repeat biopsies that we performed in August and November, which for the first time since I had met him, over a year before, showed no evidence of granulomas, no AFB on staining, and his cultures were all negative. So we were pleased. So this is the images of his response. So the PET CT There's some artifact in the muscle on the post, but otherwise you can see the lesions are significantly decreased. And then here in the images, there's significantly less nodularity. There's some residual hyperpigmentation, but to us, it was a great improvement in his lesions. We also tested his serum for anti-phage antibodies, and interestingly, he developed a robust IgG-mediated antibody response as early as day 17 that increased at 16 weeks after initiation of treatment. And there have been a number of reports in the literature that are conflicting on this front. So in certain cases, an anti-phage antibody response has correlated with a decreased treatment response or a recurrence of the infection. But in some cases, the antibody response has not impacted the treatment course. And so in our case, his lesions, despite this, his lesions remained stable. And he continued on combination antimicrobial therapy and phage therapy for actually 11 months total. And we just recently stopped phage therapy in May of this year. This is to show his antibody responses. So you can see the IgG curves here at the different time points. And then panel G is the neutralization assay at the different time points. And this is to just briefly review the case of another case with Dr. Hatfull's team and Rebecca Dedrick, who this case was an 81-year-old immunocompetent patient who had bronchiectasis and M. abscessus pulmonary disease, who had been treated for 5 years with NTM therapy for a combined MAC and M. abscessus infection. And again, they used these 3 phages. The part I didn't mention before, so muddy is the phage the original phage that was isolated from the environment, and the other 2, Zoe J and BPS, are actually were engineered to more efficiently kill the M. abscessus in these cases. And then administered in the same way, intravenous, Q12 hours. Patient had no reported adverse effects, but unfortunately he developed a potent neutralizing antibody response that correlated temporally with a rise in his M. abscessus burden on sputum. And so I thought this was an interesting contrast to our case and some of the other cases that have now been reported where an antibody response does not seem to correlate with an impact on treatment. And I think one of the interesting pieces to think about this is the patient's immune substrate. So this patient being immunocompetent versus our patient who seems to have some level of immunosuppression related to his genetic mutation, as well as the ongoing low-dose prednisone, and then in even greater contrast, the transplant patient who did not develop the neutralizing antibody response at all, I think really speaks to that we need a better understanding of the interactions between the host, the bacteriophage, and the bacteria. So finally, Dr. Hatfull's lab and Rebecca Dedrick again were able to put together all the cases that they have collaborated as a part of using microbacteriophages for non-tuberculous mycobacterial infections. So the most common pathogen, putting it all together, was M. abscessus, and most often it was pulmonary disease associated with cystic fibrosis. There really were only 7 phages total that were used for all of these cases that were found to be susceptible to the isolates or efficiently kill the isolates. And I think that's interesting and can be a part of the discussion in terms of, is there a way to move this from such an individualized sort of slow process to a more streamlined off-the-shelf process to be able to obtain phage therapy for mycobacterial diseases. And I think that there's a lot of work to be done to get to that point, but the fact that only 7 phages were used definitely, I think, is an interesting point to that. And then a number of these patients were treated with single phage therapy without any resistance observed. So that's been a major theoretical concern, but doesn't seem to play a major role in these cases. It was felt that the IV route of administration might have more efficacy than some of the other routes that have been used in the past, like inhaled or topical administrations. It seemed to be relatively safe in all of the cases. There were no major adverse events reported. And then I think one thing to consider is just, this is not the easiest treatment to administer, which, we're used to dealing with this with NTM infections. A lot of these medications are challenging. Some of them are intravenous. They have to be given for long periods of time, but it is the same for phage therapy. So intravenous, our patient had to come to the pharmacy every 9 days in order to receive syringes that held his bacteriophage doses, and he would administer them to himself twice a day. And so that's a big burden for a patient to go through, and I think definitely something to consider. And patients were treated for up to 36 months. And then, there were mixed responses, and I think that speaks to the challenges, when you're not looking at a randomized clinical trial, and in addition, how heterogeneous these presentations are. It can be really challenging to understand why it seems one patient seems to be responding and one patient doesn't. And in many cases, these are being used in conjunction with multiple other therapeutic approaches like antibiotics and surgical intervention. So that can make it really hard to truly and clearly assess the impact of the phage therapy. And then I think 8 patients had neutralizing antibodies in this series, 4 with a possible impact on treatment response. So that's another area that really, I think, deserves a lot of further studies and attention. So I think I'll go through my conclusions, and hopefully we'll have some good time here for discussion and questions. So I think phage therapy is an exciting therapeutic platform for resistant bacterial infections, and in particular non-tuberculous mycobacterial infections. I think because the pace of the disease often is, allows for this sort of slower timeline in terms of obtaining regulatory approvals, et cetera. Immunocompromised hosts will be an important population that could benefit from this treatment modality, and we may be seeing more and more patients with a variety of diseases who are receiving targeted therapies or immunotherapies that weren't previously, that could be at risk for NTMs. And then there still remain a lot of questions about dosing, route, duration, and interactions with the host immune system that need to be answered. And finally, I think clinical trials will hopefully be able to help in these areas, but certainly will be challenging to design given the heterogeneity of the patient presentations in the population. And I wanted to give one sort of update to the patient's clinical status from, when we published our paper and we had been following him. It's now been a significant period of time, and I think it really reiterates the challenges of these infections and of phage therapy. So we had stopped his phage therapy around 11 months in the setting of, the challenges with administration. He was having to come to the hospital essentially every week to pick up his doses. And we knew he had a neutralizing antibody response. We weren't really sure if the phage was having a major impact at this point. And so we decided to stop it, and we've continued him on his microbial antibiotic therapy while we've done that, hoping to make one change at a time. And he has had certainly some progression of one area of his lesion since we stopped the phage therapy, which I can show you in this picture. So the front of the arm is looking great. I think probably the best it had been and since we had known him still. but he has this one area in the sort of the posterior part that's more nodular and has been draining over the last few weeks. So he's actually going today for a biopsy, but I think it really brings up this question of like, if phage therapy did help him and was contributing, how can we continue this forever? Or, are we going to see recurrence when we stop? I think that is another interesting point for discussion. So I'm excited to see and hear everyone's thoughts on this, and I will go ahead and pause there.
Dr. Little, that was just a fantastic presentation, just masterfully done. I think probably a lot of folks are going to have questions or comments. One, I guess, question I had, which speaks to your last point, is the optimal dosing schedule for these phage products remains to be determined, right? And the PK of this is such, right, that they, to my understanding, sort of replicate in the presence of the active infection, right? And so any thoughts on what might be an ideal regimen, or are you considering sort of spacing out the dosing just for sort of patient tolerability? Do you have any sort of PK data on the titers of the phage itself after dosing that could help inform that clinical decision?
Those are really good questions. I think that was definitely a challenge that we faced, and we ended up making the decision to use that dosing because it had been used previously, but it's really challenging to sort of assess this, and it's certainly in a clinical setting. So for us, we were his physicians, we weren't in a lab. We sort of had some associated funding that we were using from colleagues, but we weren't really in the position to do a lot of additional studies. And I think Dr. Hatful's lab is in the position to do that, and hopefully is planning to move forward with clinical trials at some point in the future. So I hope that will give us more information about the pharmacokinetics of the phage. But I think, what was interesting to me was one question that we had this whole time was, did he just need the phage in the beginning? Like, was it just that because he developed the neutralizing antibodies so early? We always had wondered, did he just need the phage up front to sort of clear the burden of bacteria in addition to his surgical intervention? And then, it was really the antibiotics that were helping him after that, once we had gotten the burden of disease down. But now that he's had this worsening, after we've stopped the phage 11 months later, it really did bring up a question to me of whether or not it was having an impact even this far out, despite the fact that he had developed a pretty robust neutralizing antibody response. So I wish that we had more data on that from our case, but I'm hopeful that we will find out more in the coming years to be able to better assess that.
Other questions from the audience? Yeah. I think, and I don't have an answer to this, nor do I expect you to, but I think one sort of continued challenge is going to be identifying the ideal patient to receive mycobacteriophage therapy, right? And you alluded to the heterogeneity of clinical experience, the trend of patients who are more heavily immunosuppressed, not developing those neutralizing antibodies, and then also the discordance between the development of those antibodies and whether or not there's actually an impact on efficacy. And so, I'm curious if you or others on the call have thoughts about how can we sort of risk stratify, how can we optimally select patients that may do best with this sort of salvage therapy. Because I know a question a lot of folks are muddling around is, okay, well, even if somebody doesn't come to phage therapy with some either underlying or iatrogenic immunosuppression, are there concomitant drugs, right, that we could give, a light dusting of something immunosuppressive that would allow the phage therapy to be more efficacious? And so I think there's a lot of unknowns there. So I guess, yeah, if anybody else has thoughts on that and any of those questions, sort of risk stratification, concomitant immunosuppression that might make phage more effective. And then I guess, to the risk stratification point, are there, either blunt or very precise tests of immune suppression that we should be collecting in people in whom we're considering phage therapy? Easy ones come to mind, right? Like CD4 count and immunoglobulin levels, right? Things that we, very routinely order in our clinic. But if there are other sort of markers of immune function that might be helpful, even if we can't at this point make clinical decisions based on that data, if as a community of people, right, who are treating NTM infections and really trying to find the optimal use of this therapy, that maybe would be helpful from a retrospective epidemiologic sort of standpoint. It was a long-winded series of statements and questions. If anybody else has thoughts on any of that.
I had two thoughts on what you said. I think two pieces are very interesting. I think one is just picking the right patient, I think, is important. When I think about NTM infections, it can be so challenging. So even, a lot of times with the pulmonary infections, you might go to 4 different providers and they might recommend treatment for that patient, or not recommend treatment differently in all 4 providers. And I think, at least with the phage therapy, it's helpful. It'll be helpful to understand impact if we're really treating patients who are symptomatic, or who have, really aggressive or progressive disease. The cutaneous disease is sort of nice because you can follow that in a really clear way, clinically. But I think with some of the pulmonary cases, if the patient doesn't have a lot of symptoms at baseline, it's going to be hard to show a treatment response. You can follow the cultures and you can follow the radiology, but I think the trickiness of these cases at baseline makes it really hard to assess response with phage. And then the other thing I was just going to mention, I guess, was I hope, because I'm sort of in the realm of hem/onc transplant ID, I'm really interested in how we can better characterize patients' immune responses and immune reconstitution. And I am hopeful that, in the future, we will have much more granular ways to understand what the patient's immune status is, and that might be able to guide us more around phage therapy and any sort of concomitant treatments.
Hi, that was a great presentation. Could I ask a question about, it's kind of maybe shows my lack of knowledge about phages, but how exactly are they working? I mean, I would love if they just went into one organism and divided in that organism and spread just like viruses do in us. But is that what's going on? There's only one phage work per bacteria, and then they don't really multiply within them. And, why do you need to give it for so long? Why doesn't a dose work?
Yeah, it's a good question. So the phages are lysing the bacteria at the site of infection. I think I don't have a good answer to, exactly why not every bacteria would be killed, in that first dose. But I think it's similar to antibiotics or other treatments that we give where you have some evasion or you're not able to target every bacteria. So I think Dr. Haffel probably has a better answer on on that, the basic science level of what's happening, but it's essentially lysis. I'm not really sure in terms of, the duration. And I think we still have yet to understand why you would need to continue on for 8 months or longer.
Yeah, because lysis is growing with bacteria, and lysing it, they've overwhelmed it.
Sorry, you cut out.
Yeah, I was saying lysis would imply that they're growing within the bacteria, they're multiplying, and then when they've reached their max, they just lyse the bacteria and make their way out. But I don't know if that's actually what's happening.
It is. So it's, it's a virus for the bacteria. So you'd have to give an excessive amount of bacteriophage to kill, all the bacteria at one time. So you're infecting a couple or a few 100,000 probably bacteria. It grows within, lyses, and then infects the next bacteria.
I wish it was as efficient with the Chelonia as it is when it infects us. The viruses seem much more virulent when they hit us. They go through all our cells,
Yeah.
But thanks for your input.
Thanks for your question.
I'm seeing a comment from Melissa Bowen in the chat here, mentioning that they have a cystic fibrosis patient on his third phage for abscessus. Patients have put up with a lot of challenging therapies. Not all patients can do this. Yeah, absolutely. I think it takes a huge toll, which is why, right, if we can change the dosing frequency, make it less onerous, could potentially open it up for more patients.
Definitely.
I also have a question about, this goes more to PK, that you mentioned we know very little about. But for the pulmonary disease, if inhaled versus IV is going to be better, especially for cavitary, I'm very curious what's going to come of that, because it may, once we know that somebody can tolerate it, be easier to administer, right? If it could just be inhaled,
Yes,
plus more localized.
And I know that there are studies or cases where inhaled has been used, sometimes in conjunction, I think, with intravenous and sometimes not. But I didn't dive so deep into that literature because of my case and the fact that it was cutaneous. But I think that certainly is something that's being utilized and hopefully will be, potentially considered in clinical trials as well, so that we can better assess the impact.
And I'll just say, the case report that you brought up, where Dr. Cohen was the senior author on that, there's a subsequent publication of that same patient where he was given nebulized phage. This is the immunocompetent gentleman who was on initially IV and developed the high neutralizing antibody titers. And, it was a situation that perhaps won't be uncommon in the people that were considering using this salvage therapy, but, it's very end stage in terms of his underlying lung disease. And ultimately, by the time he was on the nebulized phage therapy, it was more of a palliating sort of framework in which it was being administered. So all we can realize, I don't think that there was a robust clinical improvement, from that nebulized treatment, but it at least seemed to be well tolerated, to your point.
And just to answer the other question I'm seeing in the chat, I think in most cases for the mycobacteriophages, they've been used as an adjunct therapy with antimicrobials. And that's sort of how we approached it, because we were worried that it might not have efficacy in our patient and didn't feel comfortable stopping his other treatments. Any other questions? I'm curious if anyone has seen the tedizolid toxicity, the mitochondrial toxicity. That was pretty profound in our patient and not something I had found a lot of. I had found a little bit in the literature on this, but I'm curious what others' experience is with that. Maybe we haven't used it enough, or maybe it was just a very rare finding.
I haven't used it a ton, just because, from looking at some of the trial data, that the initial kind of promise that it would be better tolerated, have fewer toxicities, it doesn't seem to be that dramatic of a difference. And for most patients, where I've tried to obtain it, their insurance has not readily covered it. The one where it was covered, she ultimately decided to stop therapy. So I personally have not had much experience. But yeah, if anybody else the lactic acidosis obviously has been readily, frequently, not frequently, but has been reported with linezolid. I'm curious if there's been experience of that being an excess or more commonly observed toxicity among those who have used tadalafil. Okay. I think the other, you brought up the bronzing with clofazimine, which I know we've all seen and which is sort of expected. And a lot of folks, when they observe that, will sort of drop down the dose to 50 milligrams daily as opposed to 100 milligrams. Just curious in your case whether or not you would have continued on with a higher dose, just given the fact that this was a cutaneous, infection, and obviously clofazimine penetrates quite well into the skin and soft tissues.
So for our patient, the reason we ultimately stopped the clofazimine was the prolonged QT. And so at that point, we decided just to take him off it. But I think that's an interesting approach. Definitely something to keep in mind. If we have one more second, I'm just curious if Melissa's still on the call, or maybe she left. I was just going to ask about initiating a second or third phage, because I'm concerned for our patient if he, does end up having recurrence, if that's, a path we'll have to go down. But thank you everyone for having me. It was really great.
Thanks, Dr. Little. Great presentation. Thanks everybody for joining. We'll send out an email about our next series and look forward to seeing you all then.